Hi guys. So we're going to do a quick review for the upcoming exam. Focus on a couple of the questions that I posted, and I'll walk through the solutions to those. The first question talks about rapid sequence intubation. It's pretty straightforward, I think. One of the big things to remember about this is you want to give your induction agent prior to your paralytic agent. So that really makes it pretty clear once you know that etomidate is the only induction agent listed first. You never want to give a paralytic prior to induction, and you don't want to double up on your paralytics. There's very little reason to do that. So if you know your different drugs, this question should have been pretty easy. So C is the correct answer there. Etomidate first, then rocuronium. Which of the following medications used for the treatment of hypertensive emergency is a calcium channel blocker? Nicardipine is the answer here. Again, pretty straightforward. I've gotten a few questions about the emergent medication of hypertension, and I know those tables I put in the lectures were kind of busy, to say the least. There's a lot of information on there, and of course I don't want you to know much of that other than just knowing the drugs themselves, having a general understanding of their mechanism. I think if you know what their mechanism of action is, for example, if you remember that nicardipine is a calcium channel blocker, obviously you'd get this question right, but that should tell you that it's an antihypertensive agent. And if you remember it's an IV antihypertensive agent, you should remember that it has a role in hypertensive emergency. The other thing I would know generally is what types of combinations could be used for different situations. So, and I know it looks confusing when you look at the slides, but I think it actually ends up being pretty straightforward. A lot of times a beta blocker plus a more broad spectrum agent are combined often. So for example, something like labetalol or esmolol plus nitroprusside or nicardipine would be a good example of two combinations you could look at using. Nitroglycerin is a good drug for anything cardiac related. It's like level 1 MI related stuff would fall under that branch. Enalaprilat's an IV ACE inhibitor that's rarely ever used, so I'm not really going to spend much more time on that, but I would go over those. Don't spend tons of time on those slides. I think there's a lot of information there that's not going to come up on the exam. But again, the basic stuff, like I just mentioned, is fair game. So drugs, mechanisms, combination therapy in a case situation would all be fair game. This is a patient in the emergency department in VFib. Your staff is performing high quality CPR, and you have tried shocking the patient twice. Give 2 times 1 milligram epinephrine IV. Assuming the patient is still in ventricular fibrillation, which antiarrhythmic drug and dose could be given next? So this is a case where you have a patient in VFib. So knowing your ACLS algorithms should help you out here. And knowing what drugs are antiarrhythmic. Atropine and vasopressin are not antiarrhythmic drugs, so really you're looking at choice A or B, and just knowing the dose of amiodarone. In a VFib arrest, you're going to always do pushes and higher dose of amiodarone, so that's going to be the 300 IV push. The amiodarone 150 IV over 10 minutes is more for like an unstable VTAC, where you might have a patient who's kind of borderline, looking like they might crash any second, but you don't necessarily want to give them a push of amiodarone. The biggest risk with doing that is sometimes you can cause excessive hypotension, and in an unstable patient, that could, possibly push them into a more severe clinical picture. So it's probably best to slow push that in a situation that's a little bit less severe than something like a full-on VFib or VTAC arrest or pulseless VTAC, where the full 300 milligrams push would be due. Question 4. This is a 76-year-old female, recently started on levofloxacin for community-acquired pneumonia, now in the emergency department. Her white count's up, her blood pressure is down. What treatment should be given first? So what I'm getting at here is the sepsis treatment protocol and how we approach a septic patient. I didn't come out and say sepsis, but you have a known source of pulmonary infection recently, you have an elevated white count, and you have what's looking like systemic inflammatory response, meaning her blood pressure is quite low. So when we're treating people, there's obviously several things we're going to do in rapid sequence, but the first thing you want to do is try and fluid bolus the patient, 30 ml per kilo, try and get them up, volume up, and try and give them some blood pressure support that way. You'd want to do that before you started any type of pressor drip. And while you can get your antibiotics primed and ready to go at the same time, you still want to give that fluid bolus first. So D, the normal saline bolus, is the correct answer. Okay, moving into toxicology. This is MR, 22-year-old female, psych history at your hospital, presents with acute distress. You suspect an overdose. Your EMS brought in a literal grocery bag full of various prescription, herbal, and OTC medication bottles. This bag then given to your PharmD to sort through. In the meantime, you are preparing to intubate her, and you notice a wide QRS complexes on her EKG. Also, her iStat labs come back showing a pH of 7.1. Besides RSI medications, what medication might be a good empiric choice to give? So with this case, you're looking at sort of a general overdose. You don't really know what's going on. You just know what symptoms you're looking at. So pH is a little bit, patient's looking acidotic, and the patient is having some EKG abnormalities. So I've given you two things here that should point to sodium bicarbonate. Sodium bicarbonate can help buffer the body a little bit and bring up the pH. It's a bit debatable, but it can help. The better thing is it might help stabilize the QRS complex a little bit as well and prevent the cardiac symptoms occurring from getting worse. And so sodium bicarb is going to be the first choice right now. And then you would want to assess the situation and see by that time you maybe get some bicarb going. Maybe the pharmacist has figured out what the patient might have overdosed on. It may help your treatment algorithm, but we'll go to the next part of the case for that. So you give some bicarb, things narrow a little bit, looking a little bit better. Your PharmD now finds that the patient has several prescriptions, missing large amounts of tablets. Let's say these were the following that the PharmD found. So your PharmD tells you that they're missing large amounts of citalopram, aripiprazole or Abilify, melatonin, and propranolol. So this is where some of the content on this next exam can get a little bit tricky because you do have to know which one's a beta blocker. Hopefully throughout the course you can recognize what's dangerous out of this group, and based on the tox lecture you should know that beta blocker overdoses are pretty significant in the tox world. When it comes to overdosing on something like Celexa or Abilify or melatonin, very very limited problems associated with those drugs on their own. So D, propranolol, would be the correct answer here. And part 3, so which of the following therapies would provide the most benefit in a beta blocker overdose presenting with severe bradycardia, hypotension, and EKG abnormalities? We talked about a couple different options, and this question is a little bit ambiguous. The exam is a little bit more clear of what I'd want you to do as far as what we've tried and what would maybe be first line. With a beta blocker overdose, just to review, or calcium channel blocker, you're looking at probably doing atropine and fluid boluses first. The reason why this question is a little tricky is that there probably isn't a lot of benefit in that, and the odds of a severe overdose really responding to fluid boluses and atropine to help get the heart rate back up and help with the hypotension, probably pretty slim. High-dose insulin therapy is going to be your hopefully saving grace in this situation. So A would be the correct answer here, but again, on an exam, I'd make it a little more clear what I was looking for. All right, moving on to critical care. Critical care, we have a middle-aged female patient admitted to the ICU post-overdose of benzodiazepines in the setting of chronic alcohol abuse. She was intubated in the emergency department, currently on a high-dose propofol infusion. Which of the following is not a possible risk factor for giving propofol? A, hypotension, B, propofol infusion syndrome, C, hypersensitivity, and D, high incidence of delirium. So this just requires you knowing what side effect profile propofol has. Propofol generally does tend to cause people a little bit of hypotension, so A is correct. B, unless you thought I was making that up altogether, should be obvious that that's a possibility. And C, propofol is an emulsion that's egg and soy based. There's debates in different case reports on whether or not there's any actual risk of that, but it is a theoretical risk, so that is something we might want to watch if there was a hypersensitivity history to eggs and soybeans or soy products. And D, high incidence of delirium, not really associated with propofol. Propofol is associated with a pretty low amount of delirium compared to like a midazolam infusion. So D would be the correct answer. Part 2, which of the with the propofol infusion running at a high rate, your patient is starting to show signs of physical resistance to mechanical ventilation. Assuming she's only on propofol at this time, which option would be best to try? Your options are fentanyl, boluses, or an infusion to address the analgesia component. You could add a midazolam infusion to stop likely withdrawal seizures. Remember, she's an alcoholic, so maybe she needs some benzos on board for withdrawal seizures. C, change propofol to dexmedetomidine to prevent delirium. Or D, start an infusion of cisatracurium to paralyze the patient. There's a number of ways you could go about this, and this is a tricky question. What I was trying to get at during the lecture is that propofol, for one thing, does not have an analgesic component to it. So I believe fentanyl, boluses, to see if you could add a little bit of sedative on board with the opioid component, providing some analgesic relief and hopefully helping the patient to calm down a little bit in the process, and then likely not resist the ventilation as much. But that would be, I think, the easiest thing to do out of this. A midazolam infusion, stop withdrawal seizures. I don't know if I talked about this really, but propofol actually in of itself, it's a pretty good anti-epileptic medication. It should suppress seizures pretty effectively, so that really wouldn't do anything. C, changing propofol to dexmedetomidine to prevent delirium. This patient probably isn't experiencing delirium. It's possible, and that could be an option too, but again, I think maybe some fentanyl might be a better option at this point, early in the case, or early in the patient's stay. And then paralyzing the patient altogether, unless you were on several sedatives and nothing was happening, that's not going to happen. That's not going to be the first thing you try once your propofol infusion's capped out. So again, I think fentanyl would be the best choice, but it is a bit of a tricky question, and it could depend on a lot of different scenarios. I think in this case, though, fentanyl would be the easiest intervention to give a shot to. All right, so those are the questions. So that's some of the sample stuff you could expect on the exam on Monday. I think what you can, as far as emails I've gotten, again, the biggest question I've gotten are about those hypertensive drug tables, antihypertensive drug tables, and I know that they're very busy, but I pulled them from another source, and I think that they have a lot of good information on them, so I had nothing else there to reference. But again, don't worry about all the little details, and just look at the big picture overall with those drugs, and you guys should do just fine. You'll also notice I didn't do any review questions from the very last set of slides about medication safety. The questions from that lecture will be very straightforward, and you're going to be looking at that 5-point short answer question that I talked to you guys about. Again, don't try and get too worried about that. I think the question on the exam is worded in a way that it makes pretty good sense as to what I'm looking for an answer. And I'm really just looking for something that's in your own words and something that you got out of the lecture and something you're thinking. I want to see that you're processing the concept of transitions of care, and that can involve good counseling to patients, good education. It can involve a good medrec component. There's a lot of different ways you can approach it, so it doesn't just have to be medrec focused specifically. But I think, again, it'll make sense, and you put something down that sounds reasonable to me, and I'll give you all the points for it. So that's all I'm really looking for. And again, I think the question is laid out in a way that it makes pretty good sense what types of information I want you to express on that question. So anyway, hopefully this is somewhat helpful. If you have any questions for me, feel free to email me in the next day or so, and good luck studying. Thanks.